Thank you, Dr. Lassiter. So as a reminder for those who are in the room as well as those who are virtual, please reflect on any actionable key areas that you can take away from this morning's session one and save it for a discussion this afternoon. And with that, I am going to introduce Dr. Jennifer Bacani-McKenney. Thank you.
All right. Good afternoon, right? It's noon now. Exciting. Look at us. Hopefully everybody's learning some great stuff. Really, there's a little bit of doom and gloom in there. Yeah. But today is also about hope and about things that people are doing really well. So hopefully we get a little bit of both, the urgency of why we're here today, why we have all these brilliant minds here today talking about the challenges and what we can do moving forward. So I would love to have my panelists come up as well as our speaker here. And let me do a little bit of introduction. And very nice to meet everybody. I'm Jen Bacani-McKenney. I'm the Associate Dean for Rural Medical Education here at KUMC. I'm also a practicing family doctor in rural Kansas, about 2 hours south of here in Fredonia. So if you've never vacationed there before, it's about 2,500 people. You're welcome anytime. I will set up the travel agent for you. But I will tell you that I could not be more excited to have the National Academy of Medicine here and talking about rural health, right? Like this is super, super exciting. I think for me personally, but for Kansas, as a rural doctor, as a mom, as a daughter, just people who we care for every day. We have a lot of people in urban communities like we've talked about, but in Kansas, I mean, we have so many people that are in our rural communities. And what we believe here at KU, and Dr. Samari has made this very evident, what we believe is that every single Kansan deserves access to high quality care, no matter where they live, no matter what their zip code is. And I really think that that we try to practice that, and we're working toward that. And we want that to be a sustainable workforce that lives a safe, healthy life, a healthy profession as well. So we are going to hear from some really great people today, and they're going to teach us all kinds of good stuff about what they've been doing, and we're going to have a great discussion. I know we're going into lunch, but trust me, you're going to love all the information today. We are going to be accepting questions and answers. We'll be giving answers up here. But I really think that you're going to appreciate the discussion that we're going to have up here as well. So let me introduce this all-star lineup. First of all, we have Benjamin Anderson, who it's not in his bio in the paper, but he's actually my brother from another mother. So that's a very scientific classification. But I'm excited to have him here. We met when he was out in Lakin in Western Kansas. You can also vacation there. You're probably more likely to vacation there. But he went away for a little while to the Colorado Hospital Association to work as the vice president for rural health and hospitals, where he provided leadership and direction in the development of and execution of the association's rural strategies, advocated on behalf of rural hospitals and health systems, and worked to develop strategic partnerships with organizations that affect the health of rural Americans. The cool thing is that he is coming back to Kansas as the CEO of the Hutchinson Hospital, which is a rural hospital not too far from here, but he's coming back to work on rural health in Kansas as well. So we're very happy to have him here. He's going to talk a lot about his time as the CEO of the Kearney County Hospital and what he learned there. They serve 30 nationalities of patients within a 180-mile radius. He's a recognized leader nationally. I mean, really, there's stories upon stories about what Benjamin was able to accomplish in Lakin, and we're super proud of him. He was recognized on CBS Sunday Morning and in Politico and Sports Illustrated, Athlete of the Year. No, okay, not that. And he was a rising star under 40 and modern healthcare's up and comers. So he also got his master's of healthcare delivery science degree from the Tuck School of Business at Dartmouth. So we are excited to have Benjamin. And to react to Benjamin, we've been working on our reaction faces, I think. So Margot Savoy is the Senior Vice President of Education, Inclusiveness, and Physician Wellbeing for the American Academy of Family Physicians. She's also the Associate Professor of Family and Community Medicine and Urban Bioethics at Population Health at the Lewis Katz School of Medicine and Associate Professor at the Maurice Kornberg School of Dentistry at Temple University. She oversees the AFP education portfolio from medical school through continuing medical education, the accreditation system, journal media, and directs the Center for Diversity and Health Equity. She also is the lead for Physicians Health First, the AFP's physician well-being program. And then we also have Carlton Abner, who has been serving for the last 3 decades in healthcare and in leadership. This includes more than 25 years of distinguished military service, having recently retired as a lieutenant colonel and chief nursing executive from the Kansas Air National Guard. And in 2021, Dr. Abner brought his experience and dedication to service at Kansas City University, where he is now an assistant professor and the university's first ever associate provost of campus health and wellness. In his groundbreaking role, he spearheads initiatives to cultivate a culture of health and wellness for the more than 2,500 faculty, staff, and students at the university. Dr. Abner actively volunteers his time supporting a variety of organizations that mentor and empower historically marginalized groups. So we are excited to have this crew with us, and we're going to start off with Benjamin. Come on.
Thank you all for having me. Can you hear me okay? I've got 4 kids at home, 2 10-year-olds and 2 9-year-olds. So we use our outside voice inside all the time. If you can't hear, just let me know in the back and I'll up the volume. The Sports Illustrated thing was a swimsuit issue. I often find myself following the policy people at conferences, and one time I asked Brock Slaybaugh, who's the chief operating officer of the National Rural Health Association, why do I always go after you? He happens to be an Episcopal deacon, and he said, well, that's easy. We bring the Old Testament, you bring the New Testament. He said, we bring the law and the heavy stuff, and we need a little bit of hope after that. So I'm hoping to lighten it up a little bit in here, share some solutions with you just through story. So it is really an honor to be with them and to be with all of you. I was just looking through the profiles of the people, I was just scanning through like, oh my goodness, like these people are big time. And so I am honored to be with you. I'll start with a story. I worked in the 10th most remote town in the United States, most of my healthcare's CEO career, and we were 18 miles away from the world's largest beef packing plant. I'll get into more of those details, but we practiced at the intersection of ethnic disparities and geographic disparities, and maternal health was at the center point. So as you think about maternal health being one of the most important healthcare issues in our generation, we see women of color from Somalia who experience female genital mutilation as children, like trying to conceive and bear children in the 10th most remote town in the United States, delivered by full spectrum family physicians with fellowship training in obstetrics, right? So in partnership with OBGYNs and maternal or MFMs, right? Maternal fetal medicine physicians, like all that coming together, sort of in this explosion. Well, these full scope family doctors, this picture was taken and is posted for many years at the KU School of Medicine here actually in Wichita, but it's them going into a C-section. And, so we track C-section rates and all that, but on a typical day, our physicians would practice outpatient medicine, deliver a baby, maybe by C-section, round on patients in the hospital, take care of patients in trauma, maybe somebody in a heart attack, do a colonoscopy and a vasectomy back to back, one in the hospital and one in the clinic, take care of somebody in a behavioral health crisis and do a house call with a little black bag, like, whoa. And then they're taking care of one patient's, a Somali woman, as I mentioned earlier. The next one's a Guatemalan kid whose permanent teeth are rotting out of his head at 10 years old, never seen a dentist in his life. Next to this generational Kansas farmer, next to a guy that walks in with overalls and a chin-strap beard and speaks low German and Spanish, but not English because he's from Canada or Mexico. He's German Mennonite, right? So they're processing all this at the same time, and they're seeing 30 to 35 patients a day. And then they're rounding and they're doing all the things. So the presentations, the last 2 presentations we heard around physician shortage and nursing shortage really resonate. And I've seen that happen real time. So We live in the rectangular state in the middle. So for those of you from the coast, it's one right here. And to my wife, it's the center of the universe because she was born and raised on a farm here. And we at Kearney County, we're in the little blue dot right there, little blue box in the southwest part of the rectangular state in the middle. And we took care of people, mainly birthing people from all of those counties surrounding us, driving in up to 2 hours to have a baby. All right. I didn't know this when we moved there, but as I mentioned earlier, we're the 10th most remote town in the United States, according to the Washington Post. It's not a contest I knew we were in when we moved there. We certainly didn't want to win it. But as we looked at the list closer, we realized that we were delivering babies from 88 of the 30 most remote communities in the United States. We're up there with like Montana, but you can imagine the topography in Montana versus Kansas, right? They're a little bit different. This picture was taken 6 miles east of our house. Now, quick group exercise. I want you to take that picture in and then close your eyes and take a big sniff and imagine 100-degree weather. And that's to the east of us. And there's a picture just like it to the south of us. And a picture just like it, you know where I'm going with this, to the west of us and to the north of us. No matter what way that famous Kansas wind blows, they say it smells like money. It doesn't smell like any money I've ever had in my wallet. Our kids would say that smells like Dookie. Right? It has a particular aroma, right? That's in the summertime. This picture was taken in the wintertime. I am not a meteorologist. I'm not a physicist. I'm not an expert in weather. I am from California, originally spent my summers in Texas. I'm of the opinion that icicles should not go sideways. So to use a common West Kansas phrase, that ain't right. Like something about that's not right. That's the wintertime. It's not exactly destination doctor, right? Hard to get people to go to that area. I mean, I imagine what it's like at the bottom of the Grand Canyon where you can only get there by hiking and helicopters, right? We commonly say you can't get here from there. Like wherever you're from, you can't get here from there. It's a long way out there. And so we found out who her friends are by their willingness to visit us where we live. Our hospital and our medical practice was, again, these doctors are seeing 35 patients a day, rounding on patients, doing all the things. They were charting until midnight, on call every third night, each of them delivering just under 100 babies a year, in addition to full scope family, which is unsustainable. And it was really hard to recruit into that scenario. But we had to the point of the last two speakers, had to look at environmental issues and came to this moment of clarity realization that breathing exercises actually don't fix call schedules. No matter how deep you breathe, you are still on call. Breathing exercises might be a temporary band-aid or a coping mechanism until the call schedule is addressed, but only fixing the call schedule fixes the call schedule. Mindfulness doesn't correct an unjust work environment. You can be as mindful as you want. And I'm not discounting the importance of mindfulness, right? There's good science around that, but it is not the same as correcting an unjust work environment. You can't just happy your way out of it. Good night's rest doesn't cure professional isolation. A vacation doesn't address and/or reform an absent, misguided, outdated, or even perverse reward system. We can't solve structural problems with individual solutions. It just doesn't work. But structural change is freaking hard work. It's really hard to change that stuff. I mean, it's like telling somebody who's homeless, just come tomorrow, check back in, eat right, exercise. We can't solve structural problems with individual solutions. So I'm going to switch up the framework around how we address. I'm going to show you how we switched up the framework around how we address this stuff, because we're an agricultural community. Rural America is known for ag, and we had to take this structural issue because people don't want to talk about structural racism or discrimination or those types of things in a rural area. It's like it gets political and they don't want to hear about it. So I had to translate some of this structural stuff into a language people could understand locally. So I thought, well, what could we learn about growing people from what we already know growing plants? If we think about the environment as soil and we imagine into what soil are we planting people? Is it rocky, sandy, yucky stuff? Or is it fertile? Or is it somewhere in between? What are the toxins? What's the nutrition? What does it look like? And you can often tell the condition of the soil that folks are growing in. I mean, you could tell the condition of the soil by looking at the condition of what's growing in it. And if they're wilting, like we heard in the nursing presentation. If they're frying, then it's not going to work. And we had to be honest that the condition of our soil wasn't topsoil like this. It was this stuff. Right? That's what we were trying. Hey, come on out. Be planted into this. It's like, no, thank you. I don't want to come out to that and be the fourth one on call and deliver 80 babies a year and see 30 patients today instead of 35. I don't want to come into that. There are structural issues there that you need to address first. So we used, out of the University of North Dakota School of Medicine, a community APGAR framework. Anybody familiar with community APGAR? Dave Schmitz designed this 50 criteria framework kind of around the newborn APGAR. It's a 12 or 13-year-old validated tool that looks at 50 criteria that analyzes a community's readiness to recruit primary care into their community. Now there are nursing APGARs and administrative APGARs and other things, but takes you through this process where you interview folks who work there and ask them, to the point made earlier, ask them what it's like to live and work here. And then you take that data, and we actually took it further and we bucketed, if that's actually a verb, we categorized that data into the 4 principles of soil health from the United States Department of Agriculture. Maximize living roots, minimize disturbance, maximize biodiversity, maximize soil cover. Maximize living roots, take care of existing people. Listen to them, respond to them, do what you need to do. Minimize disturbance, address the gnarly stuff that's driving them off by listening to them. Maximize biodiversity, simply remove bio. What's the organization's holistic view of diversity, including but not only race? Because that is not the only form of diversity we need to consider in this DEI journey we're on. But looking at it holistically, and it does the organization represent the population it serves? Does the leadership look like the front line? Does the front line look like the community that it's serving? Is this a psychologically safe environment for people to disagree and bring different perspectives? All those things. And the last one's soil cover. And that's essentially a concept that came out about after the Dust Bowl, when we figured out that European farming approaches weren't really working in the United States because, winds would come and blow all the nutrients out of the soil. And so it's keeping something on the ground in between harvests. It's the innovation in between harvest. And so we took that data and bucketed it in there. And we figured out that the environment was really the issue, that there were some things we needed to address. So then we had to analyze, what are the motivations of people who would want to work in an environment like that? Intentionally come to hard. There's the local kid coming back home. Merry Christmas. If we find this one, Happy New Year, Happy Hanukkah. If we find this one, there are not that many that are trained in those areas with the specific training need to go back home. But if you find them, case in point, Dr. Bakani McKinney, it's a wonderful situation for that community coming home as a legacy physician whose dad was a doctor. They're great. The foreigner, I say this acknowledging that it is very condescending, but it's often how people are treated. J1, H1B work visa physician comes into a community and they work for 3 to 4 years. They don't want to be the only one speaking Arabic in West Kansas. So they want to move to a place where their kids can relate to their own culture. They come for that coveted green card. They work their time, do their time, so to speak, and they get to an urban area. It's the federal government's, from my perspective, the federal government's attempt at fixing or band-aiding a chronic primary care shortage issue. Some of them stay and do great work. Some of them, often they don't, but not a long-term strategy for solving the issue. This one cuts up goats in the front yard, drinks a mysterious red potion, slurs his words at work, throws instruments at nurses, drops the F-bomb in inappropriate places, has an in-and-out service for high school kids that's like, highly illegal. Shows up at his interview with a significant other that he met on the road on the way to the interview. Like, we're pretty sure she's from a gentleman's club. Spits in his clear glass, right? Because he's chewing tobacco at a fancy meal, right? Those types of folks, they show up and they go out to places where they're not held accountable. If you think any of those stories, including the goat doctor guy, you think they're exaggerated, get on the Kansas State Board of Healing Arts website. All of them are there. We get some doozies, and Kansas is not alone in that, right? We are not alone in having some of these folks come out, but we're doing what we can to address this issue. There's the coaster. This one's done working, but not done getting paid. Had a couple of family situations happen that cut him half a couple of times, or had a few bad business deals, bought too many Harleys, whatever, but needs to continue to pad the retirement, but doesn't want to be on call anymore. Comes for a few years and then goes. There's the money doctor. This one pays. Pay me $750,000 to practice family medicine, and I'll go anywhere until somebody pays me $1 more, and then they're out. And the last one's the missionary, the one that's driven by a sense of mission or purpose that's greater than themselves. The greater the need, the more they're drawn there. That's the one we realize the millennial generation's full of them. Sometimes, not always by faith, but always by a sense of justice and the desire to make the crooked ways straight. They were honest in their med school interviews and stayed with it through the end of their residency and into their careers. They actually meant what they said, that they wanted to serve the underserved. We figured out that's the ones they're after. And if we can get ones with local ties, all the better. So here were our strategies as we get into this conversation together. We offered opportunities for broader clinical experience for those that were seeking them, offering opportunities when possible to customize. So if they wanted to do inpatient and outpatient care as family medicine, then we would partner. If they wanted to do OB in partnership with our OBGYNs or maternal fetal medicine folks, great. We would offer opportunities for them to do that collaboratively, that kind of thing. Offering non-traditional employment models, compensation equaling workloads. So it turns out transparent compensation is the law. We're supposed to do that, right? So we just said, here's the contract and we can customize it. If you want to work 3 days a week instead of 5, we'll make it work. Like we're all sharing the call structure equally, but we'll make this work for you so you can spend more time with your family. I've never recruited a doctor in my career, never as a superlative I'm using on purpose, without first going to them. I've sat in a lot of living rooms, like Bill Self recruits basketball players. That's how we recruited doctors. We go to them. Recruit in groups. We let the recruits recruit each other. Be quick to listen, slow to speak. Administrators that are quick to listen will attract physicians. Primarily focus on personal interests, including spouse, partner, kids. That's more important than medicine. Start there. Be transparent and equitable regarding compensation and benefits. Recruit in pairs or groups to ensure instant community. They come in with childcare coverage because their residency classmates and their spouses cover each other. Make the right thing easy, remove barriers to joining your team, hack the housing market, find the good contractors, all the things. Make sure the spouses have employment, kids have activities, and that kind of stuff. When we did that, when we turned over the soil, when we looked at the environment and acknowledged sniff test, it's us. It's not a shortage. It's the environment. We need to create safe spaces. There are actually more mission-driven physicians in the United States that want to practice in an underserved area than there are safe places to employ them, or for them to practice and work. It's not a shortage. It's an environmental and a leadership issue. All the ones in the blue, they're millennials, and they came in the following 3 years. It was so much so that we started turning away doctors, which didn't seem right because they were calling every 2 to 3 weeks. So then we started helping all of our neighbors around us recruit this way and setting up these structures and getting rich people to give us their airplanes because fuel the jet, honey, is never something I've said. So we just find people that give us their jets or jets meaning like single prop Bonanza, right? And they would fly in groups of residents from the best residencies in the country to hang out together. The governor would come out and say, hey, welcome, thank you. And then after that, every time we did that, a half a dozen more would sign contracts. And after 3 years of doing it, this is what West Kansas looked like. That's primary care access for 40,000 Western Kansas. Some of these folks, a few of them were already there. Most of them showed up afterward, the ones in the blue. Here are our outcomes in conclusion. We went from 50 new patients per week, turning away 50 patients per week to a 60% growth in primary care over a 3-year period. Went from on-call every third night and every third weekend to on-call every fifth night, every eighth weekend, from primary call to backup call, only backing up because PAs and nurse practitioners, crucial part of the workforce when we think about sustaining physician workforce, recruited them because we were basically not utilizing them previously. Went from physicians charting late into the night to physicians finishing their charting at 6 because they weren't seeing 35 patients in a day. And then net profit margin from -3% to a positive profit margin of 3% and almost eliminating entirely the tax base that was supporting our organization. We went from a HPSA score of 17 to no HPSA score to the point that we had to call the governor and say, would you give us an exception so we can keep our rural health clinic status? Because we're about to lose our rural health clinic status. We're not a health shortage. Well, it's a kind of a curveball. We didn't think about that when we brought in all these doctors. Close saying this, we can't change the weather, but there's a whole lot we can do. We can whine about the weather. We do that all the time in rural America, but there's a whole lot we can do. And I found, being in Kansas, a rich environment around training the people we were after. So to Dr. Samari's credit, to Dr. Connie McKinney's credit, to Dr. Mosier's credit, we have one of the best medical schools in the United States for turning out mission-driven family doctors. So we just started harvesting. Like, come on out. Let's create an environment where we can plant you and you can thrive and still be here 3 to 5 years from now. So with that, I think I'll turn this over to our panel and have a seat. And thank you all so much for listening.
Thank you, Benjamin. And that's the super speedy version. Imagine you get 20 minutes of like like a decade or more of like amazing work, right? So please, 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 if you have questions or thoughts, Benjamin, I think he'll have his information up there for you as well, and you can reach out to him. But now I would like to reach out to our panelists to kind of to react to some of the things that Benjamin shared with us today. So Margot, would you like to go first, Dr. Savoy?
Sure. So I'll start with just a thank you. So I'm super excited that I even got invited to be in the room. I knew this was happening, but in my brain, I hadn't really put the two and two together to think about how we talk about rural health in sort of embedded and intertwined into the well-being. Because the way I live my life, I get to do inclusion and well-being. So this is like my everyday is walking around that space. And it never occurred to me that we never did that before, that like we as a bigger group hadn't been having that conversation. Because for me, it just sort of goes hand in hand. I laughed because when Jen said, we need you to have a reaction. And I thought I was going to get emojis that I get to hold up like during different times of the talk. And so I had lots of things. I had to clap at certain parts. He totally got the side eye during the part where he was talking about resilience. I'll tell you why in a second. And then there's other parts where I just felt sad because I was like, gosh, I like cows, but you're right. I don't want to live there. And so there was lots of things going on that in my spirit when I was sort of listening to the talk. I get the pleasure of sort of seeing the medical journey from pre-medical school, medical school, all the way through to practicing docs. And what fascinates me is that we don't ever think about the fact that the problems that we create, we created. And so oftentimes when I listen to the students who are thinking about choosing medicine, what they are describing is family medicine. Like, what do you want to do? And they tell me a whole list of exciting things that they want to do. And I'm like, okay, clearly you're going to be a family doc. And then they tell me what they want to be. And it's hardly ever a family doc. It's 15 other things. And when I ask them, why are you picking all of these other things? They name off all the stuff that was on the part of your slide that was sort of the reasons why people are choosing other things to do. And if I were to add on the layer of why are you not going to, and for me, I look at this as rural and urban actually have similar problems in this space. Why are you not going back to XYZ city? And why are you not going back to XYZ county or town? Their answer is normally something along the fact of, why would I do that to myself when I could find someplace else to be where I could have more? And the things that are the more part are fascinating because it's not usually money. Like I know people think it's money. They only care about the money in as much as they need to pay off their loans because we ask them to go into incredible debt across the healthcare profession spectrum. And then they're like, I need to be able to pay those loans back. Unlike my generation who just accepted the fact that you might not get married and have children, they actually got told you could actually do that. So many of them started that even in medical school. So then you're like, hey, that $30,000 that to me seemed like I made, like, I don't know, I thought I won the lottery when I got to residency and we started making money. It's insufficient to raise a family on. And so we told them you can be all the things and you can do all the things. And then we proceed to give them situations that are impossible to do those things. So they're like, I need more money. So they're not asking for more money because they're just being superficial. They're asking for more money because they need to be able to support a lifestyle that's just a basic lifestyle. So then you're like, okay, great. They're worried about their family because now they got a spouse. So I can't just send you to Timbuktu and expect you to be okay. If your partner is like, but I have a whole job and a career too, and you can't just send me there if I can't find a place to be balanced. So you're like, well, that's interesting. I mean, I never really thought that through, but it's a good point. And then they start to talk about their children. I want a place to raise my children and want my children to have access and opportunity. And I personally was not aware necessarily of the incredible traveling sports thing that is America. But like, if you don't live close enough to be able to get your kid to like travel soccer, the whole world falls apart. If your kid can't get to travel baseball, the whole world falls apart. And if you now have to spend 6 days out of the week traveling to and from those places because you live too far away from the airport, it becomes a thing. And so how do you find your way being able to make people have that work-life balance they want, but still be able to give them the experience that they want? And honestly, most of it came back to system things. So it's figuring out how to do things differently. That doesn't mean they don't have to get done. So I would argue that, you know, the part that I get worked up about is that I don't think there should be pajama time because we should just make the people stop making the forms I had to fill out in the first place. But if you're gonna still have the form, so if I got to do this transition time, why do I have to fill out the form? Is there an AI that can fill out the form? Is there somebody else that can fill out the form? Can the computer just fill out the form with most of the information for me? Those willingness to be able to think about the actual what we need to get done, what's the work that needs to get done, and then be creative about how we could go about solving it makes a huge difference to people, even if you don't have the right answer up front. So even if you haven't gotten to the place where you figured it out, because what you tell me in the story, what you told me in the story, but when we come in here, that we didn't figure it all out day one. It's not like they woke up on day one and they were perfect. What they said was, I'm going to put in work. I'm going to listen to you, I'm going to adjust, and then I'm going to put in some more work. And so, no, I may not have the answer on day one about how to get that better, but I may be able to help you, help me, help you figure out how to do that. But I can't just say that. So what I will tell you that is fascinating, that as you watch people that go through this trajectory, my generation was willing to tolerate, maybe trusting you, and they gave you a long runway before they quit on you. So the generation ahead of us never quit on you, really. I don't know what boomers do, but they just don't. Like, they're in it for the long run. Like, they commit. I mean, they commit and they commit, and then they double down commit. And then my generation came along and we're like, well, dad said I'm supposed to commit. And so I commit, sometimes to my own detriment, which is why I actually think resilience is something we should still talk about. I think we have to talk about it slightly different, though. I don't want to train you to be more resilient. I actually need to train you to be able to distinguish between when your resilience is helpful and when it's actually harmful to you. And you can't know that if you don't realize what you're using that is a resilience technique. And so I still think there's individual work to be done. I think doctors get taught a narrative that we have to undo in some ways, because you're going to dig in, and I see it in family doctors a lot, where their mission overrides their personal protection, which gets us into a really bad situation. So there's some work still there for me. But when I think about, our generation is kind of like, well, I mean, my dad said I'm supposed to commit, so I guess I'm going to commit. But then when we look at my generation, they're like, well, I committed for about a decade. So you get me for about a decade. And I'm like, I don't think you're going to really do what you said you're going to do. And then they leave and they go do something else. And so they start to move. Well, the generation coming behind me, the millennials, are like, I ain't committing to nothing. How about you show me what you're going to do beforehand? And then I'll tell you whether or not I think I'm going to do it. I'm going to talk to 10 other people who left your place. I'm not talking to the people who work here today, the people who left your place 5 years ago, 4 years ago, 2 years ago, because I think you're full of it and I want to prove it. And I have friends, because I have the entire internet in my back door. And so they don't want to see you say, I have a wellness champion. I actually don't think the champion is the problem. You do need a wellness champion. The problem is people said I'm a wellness champion, and then they stop them from being able to do the work that actually allowed them to champion the work they need to get done. So you need someone to be accountable to that work. You need someone to do that. That by itself is an insufficient measure. And so sometimes we split hairs. And so if I was going to pick a fight, the fight I would pick is that I don't want people to take some of the things that are said and assume that we have to sort of stop doing certain things. So we're going to stop doing resilience training. We're going to stop having chief wellness officers. We no longer think it's important to do some of these other things, and everything ought to be payment reform and thinking about how to have people not be on call. I think that would be a really short-sighted view of what really needs to happen. And what I'm hearing is that we need to have a dialogue, and we need to teach people what the challenges are and then engage them in the conversation about how to fix the dialogue. And what I'm experiencing, very real, is that this is an evolution of a thing that whatever you fix today for me and my current workforce is not going to be the solution for the workforce coming down the path. And so you're going to have to be nimble and agile and able to sort of flex to what they're going to need. And I think if you don't do that now, they don't believe you in med school already. So you're having well-being, and I think you're going to get to speak to this too. They're already in med school. Like, this is not working for me. And you're like, what do you mean med school is not working for you? That's not an option. And then you're like, wait, I guess it is an option. I mean, it turns out, gosh, you could actually challenge anything. I don't know that I didn't have time to think about challenging things in school. But I started to think about, they're already aimed and geared up to do that, even in med school. So when that generation shows up and you're showing up with foolishness and shenanigans, they're not going to take that and just say, oh, I guess I'll work there. They're going to go start their own job somewhere else or go do something completely different. And unlike the rest of us who maybe only saw medicine as the end of the line, that is the job. Like, I did all of this because all I ever wanted to be was a doctor. They see I did all of that, but what I really want is to use medicine to do other things. And if you don't give them something that makes them want to stay in clinical medicine, they'll pick something else.
Thank you, Dr. Savoy. Dr. Adams.
Wholeheartedly agree with everything that Dr. Savoy said, and I like how we have had an opportunity to talk about some of the generational differences and why that's so important. So in my role at Kansas City University, which is primarily a medical school, an osteopathic medical school, which our wonderful dean of our College of Medicine, Dr. Josh Cox, is here with us today. I love this soil analogy because I feel like that's where I am, kind of upstream cultivating that soil, right? Some of it's that individual, how do I build resilience in you? But what I love about your presentation is how systemic in nature the approaches were. Now, if you layer that on, so that absolutely is where you have to start with the listening. And so what you heard here from this approach may not be what works in your communities, right? But the playbook that you can use here is that, hey, there was a listening, we figured out what was going on, and then there was a several-year process. We figured out what was working, and then featured some of the millennials that had shown up. And then what Dr. Savoy was saying about generational differences. Yeah, I'm a Gen Xer as well. It was not hard for me to show up somewhere and trust. It was just simply what you did, right? You show up and these institutions were already established. You can trust them. And what you're dealing with now, and what I'm particularly seeing in Gen Z at our university, is institutional trust is gone, waning definitely, but for a lot of people, it is just gone. You do have to show earnestly your desire to earn trust before there is a buy-in or a stickiness, particularly from an institutional standpoint, which universities represent a very well-established institution. And so there's a lot of mistrust that happens right on arrival. So how do you fix that? One of the things you heard from Benjamin was how he fostered a sense of community in the recruitment. Right now, what's happening as adolescents form, particularly in Gen Z, and probably will transition into the Gen Alpha, as the identities are formed, it's formed in a very egocentric nature, where when we grew up, community is what informed how we looked at ourselves, how we identified. Now it's more hobbies or what I believe for me personally. And so, yeah, they do show up with ideas of, oh, I can do this and this. I can have a family and do medical school. But what they need help and understanding is there is a community here that will help you. And in order for you to have resistance and resilience and be a part of something bigger is that community, is that belonging. And to put that within the recruiting effort, I think absolutely is brilliant, because as I talked about with this generation, that mistrust feels very isolating. When you show up somewhere and you are constantly evolving your identity and constantly mistrusting people, it's exhausting. And you'll see a lot of pushback from Gen Zs in particular. But when you have an element of belonging, of connectedness within your approaches with them, all of a sudden you can see shields go down. Once you've earned that trust, you can see the shields go down. Belonging happens to be the foundation of my wellness program. And again, why start there? Because nothing else matters until someone shows up and they feel like they can be their authentic self. And then you can do some of the more individual resilience building. But again, Benjamin is spot on that you also have to start with that systemic part. Like, what does the organization need to do? Students vote with their feet, employees vote with their feet. Like, what can we do with the experience that creates some stickiness, that allows people to be here, that allows people to feel like they belong in a way that they couldn't get anywhere else? Once you have that, you'll see exactly what Benjamin saw, is that you can't stop them from coming. Very, very sticky once you get them there. The last thing I'll say comes from what I've seen in the military. As I left my last position as a chief nurse, I was beginning to see this erosion of a connection to purpose or greater than self type goals. And so I couldn't rally recruitment in that regard around patriotism anymore. Flag waving, doing what's best for the country was very effective for me. It was very effective for some of the peer groups that I had. But I began to point out to my leaders of leaders that I'm not sure patriotism is going to be the thing that helps keep them here. We created other things. We did some lobbying within the state of Kansas to help Air National Guardsmen with in-state tuition and having that paid for. Great. But what else can we do? And again, there we begin to build around belonging. Like, why is patriotism important? Why is community important? What do you get out of that? And it's almost like, instead of coming from the top down, we had to build from the bottom up, connect with somebody, and then connect with somebody else, and then connect with somebody else. And then once you see the value in those connections, then you can begin to layer in some of the more institutional things that we talk about, like patriotism. But it had to first start with, why should I care? Like, which is not a bridge we had to cross. You should care for your country. Okay. You almost have to have that stuff downloaded. But for younger generations, what I'm seeing is, if you're not connecting with the why behind what you're doing, it's an immediate turnoff. Once they understand the why, then you can build upon that and help them understand the connections to what you're trying to do.
Thank you, Dr. Abner. I would just say a round of applause so far, because this is some really great stuff. I'm going to give Benjamin a chance to react to the reactions. Look at us just reacting. Are we overreacting? No, we're not. But we are going to take a question from the room because it's a jam-packed full day. We're going to take a question from the room. Since we're doing one question from the room, maybe two, it's going to be Hunger Games style. So please prepare accordingly. And then we'll take one from online. Just kidding on the Hunger Games. Okay. So, well, I did see your hand first. Good job on that one. Okay. But Benjamin, do you want to comment first or?
I love what they're talking about. And I think I didn't mention this earlier in the presentation, but we had to first, when we went after the mission-minded doctor, they knew their mission, vision, and values. They could say it in an elevator. They knew exactly what motivated them. They knew exactly what they were looking for. We didn't know our own mission statement, our own vision statement, and our own core values. If we couldn't say those things in an elevator, we lost them. Mm-hmm. Just like that, it was over. So we had in every meeting, I walked around with Subway gift cards and $20 and whatever I had to do to incentivize people to know the mission of the organization. We're committed to providing quality, compassionate healthcare services for our community to enrich the lives of our family, friends, and neighbors. You can give me that. Here's $20. If you don't know, I'm going to come back and ask you again. And it's going to be embarrassing. I'm not trying to embarrass you, but I'm going to ask you again. We just constantly in every meeting, we were reciting it. We had those things down: service with compassion, teamwork, respect, integrity, value, excellence. We knew our mission, we knew our vision, we knew our values. And when we could communicate that and we actually lived by it, then we started attracting the people they're talking about, because they were after something bigger than themselves, which is why I've never heard the connection away. I mean, not away from patriotism, but in addition to patriotism, around common mission and being part of something bigger. But we had to create that something bigger that they wanted to be part of. And I just really, really appreciate the insight of both these folks.
And I just want to say real quick to add on to that. If you are genuinely doing that, it's a unique experience for Gen Z because they're not seeing it anywhere else. So when you're genuine about that mission, when it extends beyond profit, when it extends beyond self-serving kind of outcomes, it becomes super. They're yearning for it because they're not seeing it anywhere else.
Yeah, and they want to know: is there room for me here? Is there room for all of me? Not just maybe what you think of me as a doctor. Is there room for me here? Am I going to belong? And how do I fit into the bigger puzzle? And if there is room, then I'm going to dive in, and we're going to see some of the best work we've seen generationally. We're going to see some of the best work out of this next generation when we can show them how they fit into that puzzle.
Especially if you have the opportunity to demonstrate for them how they can live their passion by being a physician still. So like what I hear a lot, which I find fascinating, is that there's this weird narrative that like you have to sell your soul and be a doctor, or you could get your medical degree and then go do your actual passion helping people, doing all these other 50 other things that you could do differently. And I mean, I just look at them dumbfounded. I'm like, I don't think you understand. Well, yeah, frontline medicine is only helping one person at a time, but I could help like people's. And I'm like, I take care of families, and that family is in a church, and that church is the bedrock of that community. And helping that one family and help them know that they had a safe place to go shifted the entire community. What are you talking about? So yes, you could go help like entire communities to do things, but I don't think you have to do it the way you're thinking about. This literally is the front door to giving you access to people. And this is one of those times where I think we could take the experience during COVID and really be more honest about the whole picture of it and not just the parts that are convenient. So like there's really the convenient part about how we all leaned in and like helped everybody, and it was great. And I felt that too. I mean, it was a great time for family medicine. All the stuff people said I couldn't do when everybody wanting to do it, suddenly they let me do when they were like, nobody wanted to do it. So like, I mean, for family medicine, in some ways, that's great time. I was well trained to help the hospital do what they wanted. But then we immediately went back to wanting to put me back in my box and stick me in a corner. And like, you don't really have privileges to do all the stuff that I thought. And you're like, what is happening right now? That's the stuff where your actions don't match your words. So when I think we're all going to die, okay, Margot, you can play the game with me. But when it's just normal business as usual, I don't really want you to play the game. I want this other more specialized fancy person to do the thing. Well, if you multiply that by like, and then I'm also going to send you to the middle of somewhere you've never been before and want you to trust that you're going to take care of me, that becomes a very difficult ask. But I could live my whole passion out during COVID because I got to use all the relationships that I had built over the years before to see that there was a pandemic coming and go to those churches and those communities and be like, y'all know I'm not a member of your church. I never have been, but y'all know I love you. And I see this thing, it's scaring the bejesus out of me. I don't know what to do with it. Here's what I do know is that right now I need you to wash your hands. Talk to me about what we have to do to help you wash your hands. Oh my gosh, it turns out we need to wear a mask. Talk to me about how I would have to work with you to get a mask in your community. But that was only because I had all that experience growing those relationships over time. And if we don't help them see that you can actually live that passion by doing the actual frontline clinical work, then the clinical work becomes secondary, it becomes an optional. And that's where we lose, I think, in rural cases. You don't have the bandwidth to have people who are there optional. Like you need the people who are there to do the work and have the passion. And when you start getting like I don't remember how you described it on your list, but the one that's like just there to hang out and coast their way out, that's a problem because you're taking up a spot. Like I actually needed somebody who could do work and you're taking up a spot, but you can actually do both. And that's a narrative that we don't share well. And if we actually talked about COVID for real, that's something that I saw like live and well, that community, that comfort, and it makes people's well-being better because you actually feel like you're part of the community. So it's not even just your physician community or healthcare community. It's literally taking care of your community. And then you dodge all that moral injury part because you actually got to help them. So it wasn't just watching things happen. You were actually a part of it.
All right. Would you like to state your question, sir?
Energetic discussions, really did. Maybe weaving in elements of Dr. Lassiter's presentation. Since the existential threat really is more nursing care rather than supply of nurses, more medical care rather than, producing physicians, aren't the solutions more reimagining top of license work rather than, say, just assigning nursing staffing ratios or panel sizes for physicians or call schedules? Just your reaction to the heavy work that needs to be done in terms of top of license work so that everybody is practicing at the top of their license.
It's a transformational leadership issue. It's a brilliant question. It's a transformational leadership issue. We have plant managers. I'll speak to rural hospitals. Many of our hospital presidents or CEOs are really effective plant managers that know how to milk a Medicare cost report for another $100,000. We need people to rethink systems that will redesign who does what. Because turns out not everything that a full spectrum family doctor is doing must be done by them. Not everything that a nurse is doing must be done by them. And it takes the ability to listen and bring in solutions from people that are on the front lines, because the best solutions to those complex problems that you're talking about are in the minds of the people most affected by them. And effective leaders can bring them in and say, how would you do it? How would you redesign it? And we start, and I used a 6-question tool my whole career. First question is, what one thing do we want to change? What one outcome do we want to improve? The second one is, who are the stakeholders that would improve the outcome? The third one is, well, what could each of those stakeholders contribute? The fourth one is, well, why isn't it already happening? Look for barriers. Fifth one, how do we measure success? Because if we don't measure, it doesn't matter. No commitment to measurements, no commitment at all. Sixth one is, when do we want to see the progress? Start with something simple, work toward the complicated stuff later. Start with the willing, let them convince the unwilling. But I think it really comes down to that skill set of redesign. And I just really appreciate your question.
I just wanted to add on to the top of licensure piece. I'm a nurse, married to a nurse who's a nurse practitioner. And we actually own a clinic here in Kansas City. It's a primary care clinic, Spanish-speaking, cash only clinic, and right off of 7th and Central, which is the heart of downtown Kansas City, Kansas. And she's a nurse. The reason why we're being able to do this is because in July of 2022, Kansas became an independent practice state for nurse practitioners. So we own a clinic, but we still have a collaborating physician. The phrase top of your license is somewhat confusing to me. Because to my understanding, there's nothing that would prevent a physician from doing surgery. Well, I don't want my family practice physician doing my heart surgery, right? Like that's practicing at the top of your license. At the same regard, while my nurse or my wife is a nurse practitioner, we feel it's very important to have a collaborating physician because we don't look at those two professions equivocally. We do believe that there is some separation, not necessarily in skill, but in an experience. Like the hours that a physician goes through before they put their hands on a patient builds an experience that I can't get for my wife as a nurse practitioner, because she literally can go, unfortunately, from business degree to nurse practitioner in this state. And I don't believe that that's a safe thing for our patients. So while I want to see people practicing at the top of their license, I think we have to do it in a graduated, in a sensical way.
Hmm.
And then the last thing I'll say is licensure is definitely something we have to get to, but even if I'm practicing at the top of my license and it's a terrible of experience, I'm not only going to leave that experience, I may leave the profession completely.
Mhm.
So I just really think that the experience that our clinicians are having is one of the most foundational things. And it's not an either or. You heard Benjamin say there were several things that they did within their iteration. So try one thing, layer something in, constantly pulling levers. Licensure is definitely one of them, but experience has to be up there as well as you're constantly pulling levers on how can I make this a better experience, like going home at 6 p.m. and not having to worry about charting.
Mhm.
Those are the things that I think you'll get a lot of bang for your buck.
Mhm.
The other thing that I think that is really important is, I am not entirely convinced that we have yet figured out what the right healthcare team is for most communities. And so when I think about something like community health workers that didn't exist when I was in medical school, but when we brought them into the practice, totally changed the way we were able to talk to the community. Because even if I did ever get to the part where I built enough family physicians who could look like the communities they came from and would go back and do that, it's going to take like a decade to get those folks back. But I can get a community health worker that's from your community that has lived experiences that are similar to yours like tomorrow. And I just have to train you to be able to help to do the things I need to be able to do. And that's not only helping for economic development in your area, giving people work to do, but also giving a voice back to people on how to take care of themselves. But that's like one random job that we came up with that we were like, we're going to call it a community health worker. And what I start to wonder is like, what are the jobs that need to be done? Like, what's the literal work that needs to get done? And then who are the people who might be able to do that? And maybe some of that work doesn't need to be done by people at all. I mean, I'm really going to buy into this idea that there may be some AI thing that if we can figure out some of the weird like health disparity stuff that's built into it, might actually carve off a whole chunk of work and push it to the side. Because I mean, it's done it in other industries. I just would find it hard to believe we're not going to do that here. So if you imagine that, and then you've got still work that needs to be done, who needs to do that work? And maybe they don't even exist today. Like maybe we haven't even trained people to do that because we didn't know that was a role. When I listen to physicians tell me now, Margot, I like the fact that my patients want to talk to me all the time. And I want to be able to give myself to them 100% of the time because I know they need the answer. I'm scared of an AI bot answering their questions, but maybe there's some other way that we could get them access to answers to their questions. It starts to make me wonder, maybe it's not a nurse and maybe it's not a community health worker and maybe it's not a doctor. Maybe it's somebody totally different. Or like in behavioral health, I think about most of the interventions we do in behavioral health don't need the psychiatrist or the psychologist there every day. They probably need more coaches and like people who can help you actually move through step by step that are trained. But like we don't even have a name for those people in a way that we use them regularly. So what's missing? And I love this idea about innovative leading change teams, like where you really start to back up. If I blew up the whole thing and started over, is this what we have built? Because if the answer is no, then why are we putting it back that way? Because we blew up the whole thing during COVID. What I heard earlier in the keynote was we fixed a whole bunch of problems during COVID, and then we're subsequently going back and deconstructing all the things that worked really well, bit by bit by bit. Why? Why not take this opportunity to blow those things up, think about them in a different way, reinvest our money in a different way. And if we don't like it, we can always change it. This is America. Like we change whatever we want. And so if we don't like it, we just go, we'll redo something different next year and do it a little bit different. But I just wonder what roles we're missing that just don't even exist.
Mhm.
Thank you. We are going to move to an online question, I believe. Do we have an online question?
Yes. And I'm going to do a two-parter. So one, how can we empower our leaders to advocate for us and demonstrate the ROI? And then what is one thing we can all do, regardless of our role and level in an organization today, that can also serve 7 generations downstream?
So I will say we're getting really close to lunchtime, by the way. So we're going to do kind of shorter answers, but we can go just a little bit over. So just ignore the food for now. That's a totally easy thing to do. And then we'll hopefully have time for one more question in the room before we break.
If I take the first half, can we repeat the second? I don't even remember what the second
No.
half was. I'll just, okay. Can I answer only the first half and then turn it
Yeah.
over? Is that-
This is America. Marco says we
all
can
right.
do it whenever we want.
4 years ago, I had a doctor walk into my office who had 3 MAs in the first year, 3 medical assistants, very well-trained physician, highly values his time and the time of other people. He was frustrated that he could not get his feet underneath him in the clinic. And I thought I was going to get an earful about how we haven't fixed the MA turnover problem in healthcare in our hospital. He didn't come in that way. To answer your first question, he walked in and he said, I have an idea. He knew I knew the problem. He said, I have an idea. He said, I visited with all 3 of my MAs who've left, and they're all leaving for $4 an hour more, and they're leaving healthcare because they can't afford the very services they're providing to our patients. They can't afford to pay someone else to check their own blood pressure. He said, but I know that we don't have a lot of money. Our hospital had 30 days of cash on hand back then. We did not a lot of runway. He said, so I visited with the CFO. I'm like, you visited with the CFO? And he said, I asked how much would it be to give everybody a $4 an hour raise plus benefits, but I know we don't have a lot of money. But then I looked at our own contracts and figured out we get $45 an hour for ER call pay. And if we just reduce that $45 an hour to $40 an hour, because we're already getting paid for collections and whatever else, just reduce that down to $40 an hour for all 7 of our partners, we could more than pay for the entire increase for all the MAs. Plus we could pay for an online certification course. So it's more than on the job training. They would get formal training with this. So I visited with all 6 of my partners. We're willing to sign a half-page addendum to our contract if you're willing to use the money for this. Could we do this? If we weren't in a pandemic and it wasn't inappropriate, I'd have kissed him. I couldn't believe it. Like, and the answer was in 90 days that was implemented and MA turnover flattened. So if you want to grab the attention of your leadership, show an interest and empathy through what they're facing. They have to figure out how to make payroll. They got to figure out how to answer to that board. And if you can grab that language, that organizational language, and meet them where they are, they will run to you. Most of the time, they will do that. And so I think that's just an example of how that can happen. MA turnover flattened and is still stable. It can happen that way. And he had the idea. It's very different if I say, hey, you want to take a pay cut so we can pay the MAs more? It doesn't work that way. But the reality for all those physicians is their compensation went up the next year because their clinic was efficient. He wasn't doing it for that, but that's the impact. The generational question, right?
Yes. The only thing I would add, I was just going to say empathy. So how do you get your leaders to listen to you? Understanding, where their interests are, what's in it for them, often referred to as the WIFM, what's in it for me, and having an understanding that how that connects to the problem you're trying to solve. You ask questions, you have empathy, and you just, in good spirit and kindness, try to solve problems together. Yeah, so that's the only thing I would add and the other thing, I think all of those things are equivocal to the second side of that question. If you have that, if you have empathy, if you ask questions, if you stay connected, if you're genuinely interested in solving problems together, that translates 7 generations down as well.
And I'll be really brief. So I completely agree on both of these sides. For me, the easiest way that I've been able to ever get bosses to listen to me is to be briefer than I think is brief, with a solution to a problem that they already know is a problem, but they haven't figured out how to fix. So if I can be the answer to their problem really fast, they'll usually let me have more time. And then the second part, the 7 generations one struck me in the presentation earlier, partly because I always think about like a generation ahead, not 7. 7 is a very, very long time. And I think about what could we do that would make, healthcare a reality 7 generations from now. And what I'm going to say is going to sound crazy, but, I think we have to figure out how to actually bring the patient back in, but without dumping all the responsibility on the patient, without giving them the resources. And for me, I always think family physicians are just a resource. I'm the mechanic telling you what you can do to be better in your community, in your household, in your life. But we'd have to put the patient in the middle, but not because we want to blame them when things are going wrong or where they can't take their medicine or they can't access whatever, but because if they're not the center of it, they will find another way to access health, because health is bigger than just medicine. So if we're thinking about the future of medicine, you got to find a way to access health and create healthy communities and spaces for them to be in. And I don't think we can do it without them telling us what they want and us being willing to bend or lean to sort of meet them somewhere in the middle, because maybe we know a little bit about certain things different than they know. But by and large, we just have to be able to find a way to help them get what they need. Otherwise, they'll just find another place to get what they need and it won't be us. And so we wouldn't be here because there'd be no reason for us to exist.
Thank you. Okay. In exchange for one more question in the room, you have to promise me that you're going to write on these little papers, right? Big ideas. You like that, Frida? See, this is a bargaining thing. So, so make sure that you're identifying one big idea for action in 2024. All right. I think we have one more question over here.
Yeah,
Tina.
I got you. I got you.
Wow, I think this could go on for another hour. So I just want to say thank you to all 3 of you. I'm still struck by like the ROI, like elephant in the room. I think it always seems to come back to that. So let's say you recruit somebody, you recruited doctors, going off of where you started, Ben, and you bring them in but you're also struggling with an access to care issue where the long wait times are 6 months out, let's say for primary care. So how do you actually lower 35 patients a day down to something that's more manageable when your CFO is also telling you something else?
Well, we had to look at finance, and we had to make sure it made sense. We had rural health clinics to work with. We had, tools that we had in our toolbox. We just had to analyze what those were. And we had to do a pro forma around it, but we knew we had such an immense need. And every time you see a Medicaid patient, it's $200, right? So we knew we could cover it. We had the volume to cover it. But it was a gamble at first because we paid all of those doctors 10 weeks of paid time off to serve anywhere in the world they wanted to go. We were recruiting medical missionaries, global health workers to come work there and saying, I'll go with you. Let's go together. Let's go to Somalia, Sudan, Ethiopia. And there's Somalia, Sudan, and Ethiopia here too. And so that was a big gamble early on. And the challenge for us wasn't profitability long run, it was cash flow. How do we cash flow it in the short run? And I actually went to a bank and said, a year from now, we're going to need $2 million from you. I'm just telling you right now, we're going to need it there, and it's going to take us 1 year to climb in and climb out of it. And they bet on us with a 3% interest rate and gave us $2 million credit card and let us do it. And then sure enough, a year later, we were out of it and we were turning black numbers. But I think it involves building trust like that and just analyzing what are all the resources. And one resource that I missed earlier, as I mentioned, KU is KCUMB. You mentioned it earlier. Osteopathic medicine has an enormous role in meeting the primary care needs in rural America. Such a high percentage of them turn out primary care. I mean, I'm thinking KCUB, Rocky Vista in Colorado, and others. And so we just had to look at all of those resources and then calculate that into the long term. And it takes a really understanding CFO. And her name was Kellyanne Speckman, and we wouldn't be here if she didn't gamble too. And she stepped into that space. But she makes good decisions. You give good people good information, they'll make good decisions. And we had to make sure the information we were giving good people was good information.
This is also why people should be advocating for value-based care or things like that. So even if you don't care about the details of the specifics, so the idea that I'm going to pay you for the team to get a certain set of outcomes means that you then have some flexibility with things that you do. So the ROI looks different. And the other part is actually getting the right data in front of the people. So if you today went and added up how much it costs to recruit a physician to replace a physician who left, and you tacked it on top of how much it costs to replace the MA and the nurse who left because the physician left because that was their doctor, like that cost, and then you multiply that over the drop in patient care that happens after a physician, particularly an established one, leaves the practice. So you actually get a gap. So you lose both income coming in because the other physicians do not absorb it. And even if you add another practitioner or another person to come and do temporary care, you still lose money. Like there's actually data that shows you lose money, and that loss of money usually persists for anywhere from 3 to 5 years after that physician leaves. And if you have a place where you continuously turn over, but people just choose to not make your practice the practice of choice, which means you have a harder chance getting people to go where you want them to go. And that means their quality metrics go off, which means all your other money comes off. And so you actually can start demonstrating an ROI that goes way bigger than if Margot quits, the world ends. Because if I leave and the world doesn't end, I mean, they're like, you just replace a Margot, it's not a big deal. But if you start tacking on the other associated costs, and we didn't even talk about the x-rays that I didn't write and the referrals that I didn't send and the surgeries that I didn't refer to you, like you can actually start showing very fast a person the ROI part. But for me, that's where I make the argument. That's why the way we're paying for healthcare today is stupid. So that you're worried about me, and you need to be worried about the whole team. And if I don't have the whole team, I'm going to burn out and quit. And since you can't let me get mental health because you're going to take away my license if I go get treated for it, then I just have to leave. And then all of a sudden, everybody's like, well, we don't have any doctors. We don't have any nurse practitioners. We don't have whatever. Well, this is where they all went. And you add all those things together and people are like, wow. So we spent $1 million to replace any one of you that decides to leave. Yeah. So all those residents that you tricked into coming here right out of residency with a promise that you knew you weren't going to fulfill, you had to go repay for all that stuff 3 years later, just when their panel almost might have been turning a profit. Like right at that moment where you might have actually been getting that money back. It's a different conversation to be had, but it's not the complaining one. It's not I'm coming in complaining to you because I don't get paid enough money. It's not even that conversation, which is how I hear a lot of people lead in. Our practice doesn't get enough money and da da da. That's not what I'm trying to fight about. I'm trying to fight about the fact that I was this close to making you money, and then my people all left because of something silly, and this is what you could have done to fix that. That changes the dynamic, and I found that people are much more responsive to that when they see the bigger picture, not just the right now, this year profit loss. Like that's hard. But if you actually look at the next year or two, it suddenly looks real different.
Yeah, what came back to that North Star, the goal was we can see you now. Not in 3 weeks, not Friday, We can see you today by somebody in our clinic. May not be your exact physician, but we can see you now. And that always gets, so all the things, the pro formas and the goals and the influencing folks and building out the systems came back to that same North Star, which is we are going to get to a point where anybody, no matter who they are, insured, uninsured, no matter their race, gender, any of that stuff, they can get in same day. And so we all were achieving that same goal. And that's fun to come into, knowing I could be part of that.
That is 100% where our ROI is, where how you can quantify bettering the experience is in that recruitment and retention, and to be able to put it in particularly panel sizes if you're in the primary care when that panel is going to turn profitable. And then you from there can make an argument. What if we, for our, right out of residency, family physicians, don't have them come in, right away with that 30 to 35. What if they come in at 25 to 30 so they can get their legs underneath them? There's some value in allowing, particularly for your Gen Z folks that are coming in, some maturation to take place, because there's a lot of social experiences that are missing out that we all grew up with that have delayed maturation for some of our younger Gen Z folks. So finding ways to do that and promoting an experience that they want to stay and that they're grateful that they chose your location will certainly show over time that you are able to make an ROI, whether that be through recruitment and retention or through your quality measures as well.
Awesome. Not too shabby. Can I get a round of applause, please, for this panel? Awesome. Thank you all so much. I know we're going to be breaking for lunch. I don't know if anybody else is dismissing you, or does anyone say no?
I think
Maybe
you have to say on your mark.
I know. This is the Hunger Games part of the day. So no, thank you so much to our panelists, Benjamin, Margot. Well, sorry, I should use your official, well, Mr. Anderson, Dr. Savoy, Dr. Abner, yada, yada. Please, if you would like to speak to them, I think they will be here for a few minutes, yada, yada, because I love these guys. So please come up and ask questions and enjoy your lunch. And then we will return shortly afterwards, I believe, at 1:45. Thank you.